So this is now because we covered actually the most key information regarding Part D data and Part D research. So here I'm going to introduce one case study we did using Part D data. So you can think loud. So I want you to actually free to unmute and just to chime in. So based on what you have learned, can we do any study on the drug utilization? So there was the idea of this case study, which we did probably 13 years ago when the Part D data first came out. Okay, let's learn about Part D data. So the best way to learn about data is to use data. So we didn't bother at all to try to even think about Part A and B data, purely using PDE record. What kind of study can we do? And that's the study we did here. So this is use of statins among Part D enrollees. So the idea is that, so we know that now Part D program is delivered through private plans, even for those who are in traditional people service program, even though they are not in MA, still they have to buy this private Part D, enroll in private Part D plans to receive a Medicare Part D benefits. And we have discussed many times, there are two different types of Part D plans, broadly MAPD versus standalone PDPs, right? So then what's the real difference or the key difference between these two types of plans, standalone versus MAPD? Well, standalone PDPs, the enrollees in standalone PDPs are in traditional fee-for-service program, right? Traditional Medicare. And those who are in MAPDs, they are in Part C, Medicare Advantage plans. Oh, that means that, okay, if you are in MAPDs, you are in the same plan. So this same plan, your plan covers all of your all types of your services, including pharmacy therapy and medical services, right? Part A and B. Now, standalone PDPs, these are private firms. These are really insurance companies, right? These private firms cover only prescription drugs. The other A and B, the medical services are covered directly by the government, by Medicare, right? So, okay, so then what does this mean? So what? Right? So what? So okay, now I can see the difference here. This is clear. So then what what difference does this difference make, right? So in other words, when the types of services covered are different, do we expect some different sort of a level of drug utilization? That was the question. So studies have shown that when you increase your medication utilization or medication adherence, right? So then people actually experience fewer hospitalizations or emergency room visits, right? That's why we emphasize on increasing or improving medication adherence, right? And there is another, and that's a very common issue. And some of you probably might be thinking about doing this study. Now you can look at the utilization. I want to see then whether they actually have a smaller number of hospitalization or an etc. Now, and also we found there is some literature on the conceptual side and then in economics literature showing that, oh, okay, when there are some different types of substitutable services, meaning that you can replace one with the other, right? So you could potentially replace emergency room visit with improved medication use. For example, like conditions like diabetes. Right. So then instead of each different individual, different insurance company covers each type of services, if one insurance company covers all types of these different the services that are substitutable, then you can actually achieve optimal level of medication, right? So now that's MAPDs. MAPDs are responsible for covering both the medical and pharmacy services, right? So what does that mean? Oh, maybe so MAPDs. If let's suppose you are running MAPDs, right? So one of your business goal is to save cost. Then how? Oh, what if we try to improve medication adherence among our enrollees? Can we actually expect some potential cost offsetting? What does that mean? So you have a Part D plans within the same business line, right? and a business umbrella, then even though you use a little bit, encourage your enrollees to use more of medications, maybe down the road, you may actually save cost in the medical service side, right? So then, okay, maybe I try to really encourage, my enrollees to stick to their the recommended treatment schedule for the Part D side. Now, standalone PDPs do not have this type of incentives, right? Because if they encourage their enrollees to use more medication use, their cost increases, but who saves cost? Medicare, right? The government, right? And if their goal is only to reduce only the pharmacy cost on pharmacy services, because they don't have to care about the cost on medical services side, right? Then they may not have incentive to steer the enrollees to, adhere the recommended medications. So there was a hypothesis. Our expectation, so the question was, is there any difference in medication adherence between these two types of Part D plans? And our hypothesis is probably MAPD enrollees will have better or improved medication adherence rates compared with those in PDP, standalone PDPs. Right, so let's compare statin adherence among beneficiaries in MAPDs versus PDPs. So why statin? Well, the, the therapeutic class, I didn't say drugs, the therapeutic class that has the highest amount of reimbursement in Part D program is anti-hyperlipidemics, right? So not just the statin, but among these anti-hyperlipidemics, statins are the dominant group. There are some other types of drugs, but usually if you have a hyperlipidemia, people take statins, right? And also for statins, we have literature that shows that lower level of statin adherence can result in the increased utilization of other medical services, increased hospitalizations, and then higher spending. So, these MAPDs will probably encourage their enrollees to improve statin adherence in order to reduce total medical cost, right? So they can save costs in the A and B line, the product line, right? So our study population, how do we select our study population? So I already said my study objective, right? And this is what you want to see. I want to compare statin adherence between MAPD and PDPs, standalone PDPs. What's our study population here? Can anyone say something? Feel free to unmute or type in. Okay, so I'm going to move. Yeah. Patient on the drug, exactly. So I'm not bothering here. Thank you. So I'm not bothering here for those. Whether you have hypertension or hyperlipidemia. No, I'm using only Part D data. So I'm going to simply define Medicare beneficiaries who filled at least one prescription for a statin in 2007. The first data we actually put our hands on. So these are users. So we defined our study population as users. And of course, we applied some inclusion criteria. Usually we focus on older adults. If you are interested in disabled or younger Medicare populations, so that you can actually impose that criteria. And also we require the beneficiaries to have both A and B coverage, and we remove the ESRD patient. And here we limit it to non-LIS beneficiaries, because one way to MAPD's plans can encourage how they can just steer their enrollees to stick to their medication adherence by providing more generous benefits. In other words, they could lower cost sharing for statins. Let's suppose all statins are preferred drug tier, so copayment is only $2 or $3, then it's probably more likely, right? So the MAPD enrollees are more likely to take statins. But if you include a low-income subsidy population, they have actually the similar level of a very low copayment, whether you're in MAPDs or standalone PDPs. So for this study, we limited to non-LIS beneficiaries. Data sources. What data do we need? PDE for sure. Anything else? Nobody's typing in. Right. So where do we get the information on this? the coverage information in ESRD, of course, yes, MBSF, but claims there.
MBSF, and then there is this LIS eligible, right, on the claim as well, when you can see that.
No, LIS information comes from only from MBSF.
Can we not do that if, for example, there is no charge in the LIS amount? Wouldn't those be non-LIS beneficiaries?
I'm not sure. I'm not. Oh, no, I'm not sure whether I understood your question. So if there is no charge on the for LIS beneficiaries, then
there's an LIS amount column, right, in the Part D data. So there's no charge in LIS amount. Wouldn't those be non-LIS beneficiaries, or?
Oh, you mean PDE record? By
Yes.
looking into PDE record, the LIS amount. So if there is LIS amount is 0, you would consider as a non-LIS. That's another way you could look at. Yes, but we do have that LIS indicators in MBSF.
Okay. Yes,
sure, yes, right. So MBSF is usually necessary not because of LIS, but we need to actually exclude ESRD beneficiaries, and then this covers the restriction as well, right? So data resources, so we have a 2007 PD records for 5% sample, MBSF file, and I obtained a plan characteristics file for to get some other variables. And then for this study, we did get actually Medspan database to identify therapeutic classes. I will cover that in the next slide. And also we used the 2000 census data to get more covariates. Now, how did we construct analytic file? You can think, I know a lot of people actually take a A and B workshop as well before they take a part D. So I'm going to assume you have used some MBSF file, and then now we have added this part D file. How do we start? So given this study, I already said that our population is statin users, and we have only PDE and MBSF file. What's the first step to construct analytic files? How do we construct the analytic file?
So don't we first pull all the patients who are on statin and then create the flags for all the ESRD patients and LIS patients?
Correct, right. So the first one step, yes, you're right. So in terms of doing research, the first step is identifying your sample, right, statin users. Now, how do you identify statin? Right. So I know it's a very easy question. Of course, we know statins based on genetic names, right? But the really tricky thing back then was that there was no genetic and brand name names on the party PDE data. It's really early days until 2010 or something. So they didn't actually append this first data records. So when we got the data first, we just didn't see any drug names. So we saw only product service ID and disease. So we actually had to get this proprietary. I wasn't aware of RX norm then, and then we got this Medspan data. I'm not here to advertise this one. We just got this one because this was developed by the faculty on the School of Pharmacy at the University of Minnesota, and I was there. And since then, I'm using this one because I'm familiar, but I don't know about other database, but I'm for sure know that the Medspan provides academic price, which is somewhat very reasonable. So it's something affordable if you have some fund, right? So now, so here you have a therapeutic drug class code and the NDC, and we also get the genetic name as well from this Medspan data. So once we identified all the NDCs, now the next step is identifying statin users, right? So we linked this Medspan database to PDE records by NDC, which is a product service ID, so that we can select statin users. Now, what variables would you keep from PDE records? I usually keep the only necessary variables to save my server space. So what are the really key PDE variables to keep in order to look at medication adherence?
Patient IDs, then the product service IDs, then there is the days of supply, the quantity dispensed.
Right. So right. Dates, yes, we covered a very good. So we covered 3 key variables: a product service ID, service date, days of supply, key variables, right? Then of course, yes, we do need Benny ID always, right? So Benny ID, and I'm always looking into country guide plan. This one you really want to get because we are comparing MAPD versus PDPs, right? So you want to actually get this plan character information of characteristic information from this plan files. So you need to link to the plan characteristics file, product service ID and service dates, and they just apply. And I also included the benefit phase as well. Thank you for those who answered on the chat box, events, right, dates and right. So now we selected this our study sample. What's the next step? Then, as I think Devansh, if I pronounce correct, as she already answered that, now we apply the sample selection criteria, right? So obtain demographic characteristics and Medicare enrollment information from MBSF. So we link to the MBSF file. Again, I'm sorry, back then it used to be called the beneficiary summary file, just the BSF. Now it's called the master beneficiary summary file. So we get this age, gender, race, and this LIS status, ASRD status, and zip code information from MBSF file. Then we excluded these folks, right? And then next we began to add covariates. So the first covariate, so now we have only PDE data, right? Think about it. I don't have any condition. How can I measure health risk? Right, we sometimes use a lot of sort of condition indicators, or you may actually want to construct some Charlson score or something, but we don't. We have only PDE data. So we wanted to measure, we wanted to get this variable, just the number of prescription drugs taken. In other words, if the more drugs you are on, the sicker you are likely, right? Oh, wait a second, what do you mean by prescription drugs? How do you count number of prescription drugs? Are you going to count different indices they are on, different brand name they are on, or different generic name they are on? How do you count, right? In order to capture risk. So the idea of risk is, so if I had A and B data, I would have included probably condition indicators, right? So here, so to me, the prescription drugs is a replacement proxy for the condition or risk. So we measured this based on therapeutic class. In other words, if you are in anti-hyperlipidemia, everyone is anti-hyperlipidemia because it's statin use. But if you're in anti-diabetics, that means that this beneficiary has diabetes. If you're on anti-hypertension, this beneficiary has hypertension. If you're on any cancer drugs, chemotherapy, this beneficiary has cancer, right? So we just count the number of therapeutic class. And you don't want to really count the number of NDCs here, right? And also we actually, this was just for this project, we obtained this HCC score eventually for all beneficiaries. And then socioeconomic variables, we obtained from census record based probably at the zip level or county level. I don't remember exactly, but these days we can use American Community Service Survey, American Community Survey ACS file. They have all the zip level information on the socioeconomic status. And then from the plan characteristics file, we use the only benefit base file. And here the MAPD versus the PDP using org type or plan type variables. And we require the 12-month continuous enrollment in those plans. And then we constructed the benefit schemes of it's two categories, basic versus enhanced. And back then it was really important whether they have coverage for the donut hole or a gap or not. So we created the indicator of having gap coverage. So these benefit information came from plan characteristics file. Right. So this diagram simply shows what I have discovered, discussed in just the graph, so that you can actually follow. And this just shows our sort of flow chart, flow chart, and you can take a look when you go about your own work and how to construct the analytic files, right? Do you need to exclude employer-sponsored plan individual? In this case, yes. And automatically they are excluded here when we constructed benefit indicators enrollees in employer-sponsored plans, they simply don't have this information. It's missing, so they are automatically excluded. I could have actually applied the criteria from the beginning in the sample selection criteria. Thank you for the question. So yeah, I'm going to move on. Right. So this is the MPR, the measure that we used. So because we have only 1 year of data, we counted that our denominator is a number of days between first prescription filled in 2007 and to the December 31st, 2007. And then we summed up the days supplied in 2007, which means that we're going to subtract the portion that's carried over to 2008. So this is a continuous variable. We constructed MPR, but because of the issues we saw, like some people will have MPR greater than 1, so we truncated them actually even in the continuous variable, but we also constructed good adherence indicator defined as MPR is greater than 80%. So this just shows a diagram here. This patient started statin fills on March 4th. This is the first fill. So we count the days of total days in 2007 from March 4th. Here in the denominator, the numerator is simply summing up these days supplied 1, 2, 3, 4, and the portion that actually carries over to 2008, we subtract them from the sum of days supplied. That was our MPR measure. And analysis was a really simple analysis. We just did a propensity score matching. I'm very well aware this is based on only observed characteristics. But this was our just a simple comparison, right? So we constructed a propensity score of enrolling in MAPDs from the logistic regressions, including all the covariates we had. And then it was one-to-one matching. We want to actually create a very narrow, tight sort of the similar characteristics. So we used the one-to-one without replacement with the nearest neighbor matching with a caliper of 1.01 and 0.01. And then we check the similarities of covariates using standardized differences. This measures, it is very similar to t-statistics, but it's not a function of a sample size. And usually if it's greater than 10, that indicates imbalance. It's not balanced. So this is a formula for standardized differences. And you can see here between full sample, meaning that before matching, unmatched sample, and then matched sample, unmatched sample, you can see it's very clearly different sort of beneficiary the sample characteristics between MAPD and PDP. A lot of PDP folks reached ICL is a donut hole. They already hit the coverage gap back then. More blacks in MAPDs, and you can see these are really not balanced before matching. But after matching, you can see here somewhat, and no variable has actually standardized differences greater than 10. So we said, oh, these are pretty much balanced samples, right? Okay, so these are the results. So this is a difference. This is a simple mean difference. So this is a before matching, which I call simply unadjusted or unmatched sample. Wow, it's very similar, right? So MPR, MPR is, which means that this is just the average 0.7, right? I just expressed it as a percent. So it's a 0.705 and 0.705. It's almost the same between these two groups. Now, in the matched sample, we see very slightly higher MPR in the MAPD, right? Among MAPD enrollees, it's only 1.36 percentage point higher. It's very small difference in MPR. This I actually converted this one. So how many more days they have, statins compared with the PDP enrollees? This is actually translated into 5 days more. So it's really not really meaningful. However, it was statistically significant. Right. Now, the next result is using this logistic regression, because we defined this good adherence as indicator, MPR greater than 80%. Again, in the unmatched sample, there was a very similar between MAPD and PDPs. And in the matched sample, MAPD has 1.7 percentage point higher in terms of a probability of having a good statin adherence, right? All right. So in summary, so we found a significant but very small differences in statin adherence between MAPD and PDP enrollees. We don't think this difference was clinically meaningful. So we concluded that our finding did not provide support for our hypothesis. But another finding is, I don't think that this actually applies in 2023 or 21 or something, but the proportion of a Part D in general, whether it's MAPD or PDP, who had good statin adherence in 2007 was pretty low. It was less than 50% in both MAPD and PDP plans. So we need to actually work on more to improve an overall Medicare population to improve medication adherence. Right. So limitations are, of course, the unmeasured characteristics can influence statin adherence, and the distribution of unmeasured characteristics can be different between two types of plans. And we did not follow up long-term adherence, and we didn't examine switching to other alternative drugs. But statins are mainstream, so we don't think this is really have big impact on the study, and also result may not generalize to other therapeutic class. And another thing here is that this is what we actually missed, not have because we didn't have A and B data. We decided not to use A and B data actually. So we did not account for hospitalizations, which means that if you are hospitalized, it's very likely you are taking statins if you are statin users at the hospital during hospital stay, but they don't show up in Part D data, right? So the better way to do is that if you have A and B data, you actually get the days that they are in, not days or days they are in hospital stays, and you probably want to subtract that the number of hospital stays from the denominator. So we might actually have underestimated MPI, the statin use a little bit. Now, okay, so then why did not find the evidence supporting our hypothesis? So one possibility is that both MAPDs and PDPs may have contracted out with the same pharmacy benefit management, PBMs. So these PBMs usually sort of, they work a lot on benefit schemes or reaching out to enrollees and sending out pamphlets. Are you taking statins? Or what about this? And something like so. So those roles are rather than MAPDs or PDPs, it's on the PBMs. But we have not many PBMs. These are very concentrated markets. So a lot of the MAPDs and PDPs have the same PBMs, which means that probably the approach to improve statin adherence may have been similar between MAPDs and PDPs. And also another possibility is that the reasons for taking statins, because we selected our sample based on statin users, right? But who are these users? There might be really huge variation in why they take statins. So some people take statins even without they have cardiovascular conditions because for the preventive purpose, right? So those folks may not really have a high statin adherence or maybe on and off or something. So the reasons for taking statins may be different. So if there was a larger proportion of MAPD enrollees who took statins for primary prevention, right, before they develop any cardiovascular disease, then they might actually not have a really high statin adherence. I expected actually the statin adherence would be much higher in MAPDs, but why they are taking? So one possibility. So not thinking about A and B claims data, I was thinking about only Part D data. Is there any way we could have addressed this issue? Possibly, yes. You could have actually see that whether these statin users are on beta blockers or not. So if you are not on the beta blockers, then you may be actually taking statins as a preventive purposes. That could have been one way to do that. Right. But anyway, so unless you are really limited, I would really encourage you to actually get A and B data and do more meaningful research. But this was a really fun and interesting study to learn the data sets.